Well, this has been a great discussion. I appreciate you guys taking out time from your busy schedule to join me today and discussing a lot of information. We reviewed a lot of important information today about the use of immunotherapy and the treatment of heme malignancies. And to close, I'd like to get some final thoughts from each of the panelists. Let's start with you, Ivan. What do you think?
Well, so I think a few things. One, I think, is immunotherapy is here to stay. As my boss says, there's two types of people in the world. There's those that believe in immunotherapy and those that will believe in immunotherapy. And, and I think in either case, we're here. The points that I think need to be made is that in terms of clinical trial or practical clinical endpoints, we have to maybe rethink what we're looking at in terms of interpretation of data. This concept of a tail or of a delayed response is a very important concept in immunotherapy. We sort of mentioned this with regard to elotuzumab, but I think there's a lot of other examples with ipilimumab in melanoma and a variety of other diseases where what immunotherapy can do is provide a long tail of response. And so from a clinical trials perspective, how are we going to interpret these data in terms of the primary endpoints? Is it going to be a median progression-free survival? Is it going to be a progression-free survival at a predefined time point? Is it going to be a hazard ratio? These are the kinds of questions that we need to look at. I think the other point is going to be how are we going to identify patients that are ideal candidates for these immunotherapies? I discussed earlier, our autoimmune disease is going to be precluded from a lot of these therapies. Are we going to look at certain types of immunotherapy in the setting of advanced disease, such as CAR T cells, and in contrast, a vaccine therapy in the setting of minimal residual disease? And all of this is going to be fleshed out, I think, in the next few years as more of these trials are coming to the foreground.
That's great. Madhav, any comments?
No, I agree with Ivan that immunotherapy is really here to stay. As a matter of fact, Science magazine called it the breakthrough of the year last year. And I think one big difference for immunologic approaches compared to many of the others has been that they not only give you durable responses, but also they allow you to target things that are drug resistant. And so there's going to be a totally different way of approaching cancer. And I think, in my view, probably a few years from now, when we have all these agents coming into the pipeline, in terms of we'll have to rethink our algorithms about how we approach early disease as well. We didn't talk about prevention too much today, but that's yet another field where I think immunotherapy is going to play a major role. So I think things are about to change in the context of it. So I'm very, very optimistic about it.
Very, very nice. Dan, any final comments?
Yeah, so acute lymphoblastic leukemia is the most common cancer in children, but it's equally distributed between adults and children. This is the most curable cancer in pediatrics. In adults, it's not the case. And the last 40 years, nothing has changed. In the last few years, we are seeing really a revolution. And the progress is much more than we see in acute myeloid leukemia. First, the revisiting chemotherapy and using pediatric protocols. The second one is better identifying who are the good patients who have less good prognosis by genetically testing the cells, and we can now identify better, and also during the treatment, the response by MRD. And that sets the stage to look at immunotherapy, because now you can use it on its own, but you can use it with better chemotherapy. You also know better who are the patients that are going to do good or bad. And this is a total leap in the concepts of treating that you probably will overcome resistance to chemotherapy. This is a totally different model of approach. So in adult ALL, I can see now, and I hope if I'll be invited here in 5 years, the overall survival is going to get, at least in the young patients, I don't know, up to age, we think up to age 60, it will approach that of children. Maybe not the same because adults have comorbidities, but it will approach that of children. And I think these three factors that I mentioned will be contributing. And immunotherapy is at the forefront of the development of a cure of ALL.
Thank you, Dan. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.